As you correctly pointed out, a slightly provocative question, better use of health data? The answer is blowing in the wind. I'm going to talk to you about the OSCAR project, which stands for One Stop Shop for Clinical Research, a project that we are currently in the process of implementing in Denmark. And I am the project manager for the project. I'm also the CEO of Data Fair, which is a company we created 3 years ago with the clear intention of trying to do what we can as a private company, building collaborations with other partners to enable better use of existing healthcare data in order to offer better treatment for patients. So, to get back to the question, data, is that the energy source of the 21st century? I think there's agreement on that. It was on the front cover of The Economist a couple of years ago. Is it the new oil, or is it something completely different? And speaking from a Danish perspective, we think it is very much different. We see data more like wind or wind power, because data cannot be controlled. It must be shared, and it must be used where it is. In other words, you don't try to bring the wind to where you place your turbines. You place your turbines where you have the best wind. You can say that wind is everywhere, all over the world, like data, but some areas of the world have better wind and more wind than others. And we believe that in Denmark, we have very good, high quality wind because we have very good data. And as the minister was just explaining to you before, that pertains to a number of different areas. So let me just give you a quick snapshot of it here. We have large number of clinical registries with long history. So basically, we've been manually registering patient data for decades. We have 100% use of electronic medical records in the hospital sector. Some of them are going back to 1980s. I can log on and within 2 seconds get the medical record for when I was hospitalized in 1988, as an example. We have 100% use of electronic medical records by the general practitioners. So the data is there. We have a fast uptake of electronic care journals. So that is basically the services offered by the municipalities in Denmark. It's not 100%, but it's rapidly growing. And then we have something that's really important when you're talking about data, if you want to reuse the data, and that is trust. We have a high level of trust between citizens and public institutions. That is not something you can take for given. It is something when you're working with data and want to reuse data that you always have to keep in mind. How do I make sure that I do not reduce that trust, but preferably try to increase the trust between citizens and institutions? And then we have something unique to Denmark and to a few other countries in the world. All this data that I'm showing you here can be linked via one unique identifier, which is the social security number. We also see GDPR not as a constraint, but rather as an enabler, because a lot of the data is health data, which is owned, you can say, or at least held in custody by public institutions providing healthcare in Denmark. But there's a lot of other data that is also relevant for health, but may not be considered health data in itself. Your fitness data, your activity data, your consumption data, what you buy, what you eat. Those information are also relevant. And we, in order to get a full picture of the individual and of individual patients. And here GDPR is actually an enabler because it grants citizens the right to those data. So if we can aggregate that data with a consent from the individual, we can add that to the healthcare data and get a much fuller picture. And then finally, having a lot of data is nice, but if that data is not structured in a way that actually makes it easy for you to reuse it, then it's complicated. And what we are seeing in Denmark is a sustained effort to prepare data for secondary use. So overall, we have good data, we have data for many years, and we have data in a structured shape and form that enables us to start building projects where we will reuse that data. So let me just take you through a couple of key points here. I want to talk a little bit about the innovation challenge in the OSCAR project. What is it we set out to do on this background of health data? What is the vision and scope for the project? Who are the partners? What are the deliverables? And how do we, through those deliverables, create value? And what is a European and even global perspective with the things that we try to achieve in the OSCAR project? Now, the innovation challenge is quite clear. We want to realize the clear potential in better use of real-world health data. That will give us better insight into disease, into treatment, and into real-world effect. It can be an important step towards precision medicine. And in that way, it can increase the effectiveness of treatments to the benefit of patients. And it can also increase the efficiency in healthcare provision to the benefit of taxpayers, basically to the benefit of all. The OSCAR project was a project that was started by the Danish Innovation Fund that contacted DataFair and Roche, the pharmaceutical company, and said, we have spent a lot of money trying to support initiatives to improve access to health data. A lot of those projects succeed, but very little stands after the project has been finalized. And so they approached a private company and said, let's try and take it from a user perspective, from pharmaceutical companies as representatives of the life science industry. If we were to build a project where your willingness to pay for insight, not for the data, but for insight based on data, if we were to build a system where your willingness to pay would fund the system, what would that look like? And that was the starting point for the OSCAR project. And so we created it as a partnership for value-based health care, building a sustainable business model on broad, fast, and secure access to Danish real-world evidence. That is our vision, and that is our objective. Now, once you do that, it's all about making a partnership, having the right partners in a project, and make that partnership into a real fellowship. And we believe we've been quite successful so far in this. We are still in the first episode of Lord of the Rings, but we have a strong and broad fellowship. We have almost all the major public institutions with responsibility for health: Statistics Denmark, the Danish Health Data Authority, Copenhagen University Hospital, AMGROS, which is the buyer of drugs for the hospital sector in Denmark, a number of smaller, very innovative companies, my own company, DataFair, Cicata, which is a world-class company in using and developing and using encryption technologies. We have Inversion, and then we have also as a partner, Roche. And when you look at the public advisory boards, that also includes the Danish Medicines Council, it includes Trial Nation, the Danish Medical Societies, the Association of Danish Regions that own the entire hospital sector in Denmark. So we managed to build a strong fellowship or a partnership, and now we are turning that into a fellowship. And we've done that from the start, and that was an objective in itself. Make sure you have the right partners with you. And then we've also managed to build a strong private advisory board. And we have today more than 22 life science companies, pharmaceutical companies that are present in Denmark. So this is actually no longer an exhaustive list, and it's growing, I would say, by the week. And I think we may soon have 30 different companies that all do clinical research and have an interest in using Danish data to gain insight. So the innovation challenge in the OSCAR project, well, from my perspective, what is how do you set about doing innovation? Well, you need to have the freedom to try and the right to fail. That's sort of the basics for innovation. And then we added to that in this project that we gave ourselves some constraints, because innovation is really when you try to overcome constraints. So we want to make sure that we can provide real world insight. The insight should be able to support all phases of the value chain in drug development and in healthcare provision. It should also cover both prevention and prediction. So basically the whole patient journey. And it should be able to enable personalized medicine. So those are the constraints we set us. So the freedom to try, the right to fail, a number of clear constraints, and then a real will to succeed. This project is not just a project where you have 10 different organizations that have come together and agreed, let's give our distinct individual efforts a common name. No, this is a project where we work together almost like one organization with a clear goal. And this is how we manage the project, like if it was one organization. What are the deliverables? What is it that we have promised or are trying to, hopefully will be able to deliver? Because when there's an innovation challenge, there's also a risk. We are testing and developing and implementing a new technology for secure and privacy respecting data sharing. In essence, it's based on multi-party computation technology, and that means that data is encrypted in all stages, at rest, in process, and in transit. We're also looking into streamlining the approval process, because you can have a very efficient technology, but if the decisions surrounding access to data and the use of the technology are not optimized, then you still have a very slow process. So we are looking into what is possible within the current legal framework, and even recommending or proposing areas where we believe the framework may need to be changed. Then we are trying to document the effect of more personalized treatment. We are building a cohort with more than 2,000 patients that are being fully genome sequenced, cancer patients at the Copenhagen University Hospital, in order to see if we have the information from the sequencing before we start the treatment, will we be able to offer more personalized treatment from the outset? And hopefully that'll give us insights that will then also allow us to offer new drugs. And here we want to make sure that we have pricing models that match the new drugs, meaning that in cancer, for example, can be very expensive, new drugs. So we want to build a data model that makes it possible for the insurers to say, we will pay for this drug if it has the effect that you are promising us it will have. And if not, you will reimburse us again. In order to make those models, you need to have a data model behind it. And that's what we're also trying to build. And then finally, back to where we started, the initial challenge, we want to build this, not just a project, but before the project is over, we will actually have created an organization with a separate legal identity that will continue to function in the future, and where its operations and its further development will be financed by the users. So where are we? What kind of services will Oscar be able to offer? Here we have showed the first 17 different services that are being tested or have been tested, validated by the private advisory board. These are areas where pharmaceutical companies need to have more insight and where they believe existing data, real-world evidence can help them. And it covers everything from the early stages of drug development, identification of business opportunities. It covers the whole area of clinical trials. You can use it to make your trials more efficient. You can use to reanalyze failed clinical trials. It covers the phase 4 and life cycle management of a drug once it is on the market, and also the health economic assessment. So basically 17 different clear, distinct services that we will be able to offer in a global marketplace based on access to Danish data. So that's very nice. Congratulations, you have your little project in Denmark. You are 5.6 million people. What does that matter to the European health database and to the world? Well, we think actually that what we are trying to test here is really interesting. Not so much perhaps the project model, but the data model and the technology we are testing. We have been invited to participate in the Towards European Health Database work groups. And I understand that currently there are two perspectives on how to combine or secure a single access to European data. You can either try one opportunity, or one option is to collect all the data in one place, make a large data warehouse. And the other way of doing it would be to have technology that allows you to access data that are located in very different spaces. Basically, back to the wind, where the wind is, but to combine those data while you're making your calculations on the data and do that in an encrypted stage. So we can have the same safety and security model as if the data was in one secure data warehouse, but we will be able to access data from many different places and yet work with this data as if they were in one place. So those are the implications that we're trying to position the Oscar project as a potential pilot or use case for the work that's currently taking place in the European health data space. So to sum it up, what we are trying to do in the Oscar project is building a complete value chain for personalized medicine. We base it on really good real-world data that we have in windy Denmark. And it is windy, by the way, in Denmark. We have a strong partnership behind an ambitious project, and we are trying to develop that partnership into a fellowship. We are using groundbreaking technology that is truly state-of-the-art on a global scale. And if we succeed, then we think we have something that has potential global implications for better, secure use of health data. Thank you very much.
Thank you very much. Well, Mr. Mortensen, it's written here with your name, Mr. Mortensen. What are the key elements to learn from Denmark in building trust with society in sharing health data? That's an extremely important question, and it comes here again and again and again in this summit. What's behind the trust in Danish experience?
Well, I think we are fortunate in Denmark that there is already a high degree of trust. So we are starting from a favorite or a good starting point. But in terms of once you then building onwards from there, I think it's important that you, well, first of all, that you have the right, that you build a strong coalition, and that everything you do, you always make a sort of a risk assessment. You say, how might this impact positively or negatively on the trust in the people? I think that's a key thing. And then it's also about the communication. And we are very focused on communicating in the right way and in the right sequence. If you only communicate about health data as this is about making business for pharmaceutical companies or making a Danish industry growth through better use of Danish data, then it has very little interest for very few people. So it's important to communicate what is the ultimate objective here. And the ultimate objective is to be able to offer better treatment to patients at lower cost with fewer side effects. That is the ultimate goal. Better access to health data can never be the objective in itself. It is only an instrument to reach another objective. And for us, that objective is better healthcare for the benefit of patients. And that is a message that should be repeated again and again.
Thank you very much indeed. I'm absolutely happy that we are already, we can borrow the messages and the keywords, in fact, to use also in our digital strategy of healthcare. The next question is how to move the needle between talking to bring value to patients to actually implementing value-based healthcare approaches. Maybe it goes hand in hand with the previous question, but still, from words and slogans into actions, how to do that?
Yeah, I think in a way, what we are trying to do in this project is having a clear focus on developing actual solutions. So while we are doing this, there are a number of initiatives, as the minister also mentioned before me, trying to prepare the ground and move the political system. It takes longer and it always involves analysis of barriers and policy guidelines. We are saying, okay, very specifically, where can we actually get access to data? How can we implement a solution that will benefit patients directly? So it's very much about the focus you have. And I think it's also in the DNA, the idea is that Oscar, once it's no longer a project, but an organization, it'll be an organization that functions on commercial terms. So we are very focused on finding solutions and to problems that people are willing to pay for, and they're willing to pay for them because they respond to a real problem.
Thank you.
So basically the point is make sure that it's needs driven. If from a policy perspective, you always have to think about equality vis-a-vis patients, but also vis-a-vis geography in your country. If you make an initiative, all parts of the country will need to have the same access. In a project like ours, the benefit we have is to say this is needs driven. So that is a built-in inequality. The biggest needs come first. That helps.
The biggest need comes first. Thank you very much. I believe also a very valuable conclusion from you is from a mindset change from project-based thinking to organizational or sustainable way of thinking. Thank you very much. I believe extremely valuable information. Thank you and have a nice day.